Hi, everyone. I'm Rose Gerber, COA's Director of Patient Advocacy and Education. As always, I'm so happy that you can join us today. Before I introduce our guest, I have a few updates for you. The most important one right now is what we have coming up. On May 8th, we're going to be going to Capitol Hill. And when I say we, patients, cancer survivors, caregivers, nurses, oncologists, our practice administrators. And if you are a patient or a caregiver or a survivor, and you were treated in an independent community oncology practice, you could be eligible for a scholarship, most likely will be. This is an exciting opportunity. We're providing a full travel scholarship, which means your flights are covered and your hotel is covered. And right now we have a great group already assembled. We have advocates coming from across the United States. If you are interested, you need to act very quickly because very soon we'll just be completely closing our hotel block. For more information, just go to our website, and hopefully you're already signed up for our CPAN news bulletin. But if not, just go to the news bulletin on the website and go to our April news bulletin, and there you'll see some additional information. Another important update is I like to share exciting news. And for those of you that were at our Community Oncology Conference recently, I hope you share the same enthusiasm that I do about how well the conference went. We received a lot of great comments. And by the way, you should be receiving a survey for those of you who might not have filled out the survey on the app in the next few days. And what I found really exciting is our keynote speaker. I'm always excited about our keynote speaker, but not being a sports fan, our keynote speaker this year was Joe Theismann, Heisman Trophy winner. And he was absolutely one of the most incredible keynote speakers I've seen. I'm sure he has a ton of practice with this stuff, but he was just so funny, so talented, so relatable, and just did a really, really terrific job. And it was just a great tone to start for the conference. Speaking of the conference, as we continue to talk about the conference, over a 2-day period, we had sessions in the general track, the business track, pharmacy track, and all of these sessions, as you can imagine, are related to both the clinical side and the business side of oncology. Of course, my favorite session was the session called The Power of Advocacy. And I was joined by Dr. Talukian, Dr. Emily Talukian, who also serves as our CPAN medical co-chair. And we also had a journalist and a government relations expert who is also an elected official join us on stage. And our whole purpose, our goal for the session was to demonstrate and give examples of the many different ways that you can become an advocate. And we got a lot of great feedback. So again, thank you. Thank you for those that have already sent in your feedback. As you might imagine as well, we had so many sessions, but we definitely had sessions that really matter to COA that are very high advocacy priority topics. And that includes our ongoing issues with pharmacy benefit manager abuses or PBM abuses. We're very focused on health equity, and we're also focused on any issues related to the future oncology workforce. And on that note, our other CPAN medical co-chair, Dr. Harsha Vyas, was a panelist in a session providing insight into the ongoing challenges with the oncology workforce shortages and just how we can bring fellows into the community oncology mix. And of course, we had people like Nick Ferreyros, who's going to be our guest today, and Ted Ocon and other leaders in national healthcare policy talk about the changing landscape in Washington and what some of the key issues are in that changing landscape and how all those issues impact local patient care. So now it's my pleasure to introduce Nick Ferreyros, our Managing Director of Policy, Advocacy, and Communications, who's going to give us some highlights on some of these topics that I just mentioned to you. Nick, welcome.
Thanks, Rose. I echo what you said. It was a really, really fantastic conference. It's always tough year after year to one up ourselves, right? Like how do we make it better? But really fantastic, 1,800 people. One of my favorite things is always your gathering of the advocates.
Yeah.
You did, which was a wonderful that couple hours there, that dinner and briefing, and we had 20 or 30 people. It was really, really nice, and of course all the advocacy leaders, many of which I'm sure are on with us.
Yes, of course. Thank you, Nick. They were fantastic. Thank you for mentioning that as well.
And yeah, and in addition to the survey Rose mentioned, the recordings are going up shortly. So if you registered and attended, you'll get to relive and rewatch everything, catch up on the sessions you didn't get to see, including the Advocacy Matters panel that Rose was referencing, which was really, really interesting. You get to hear firsthand from a journalist and an elected official on what matters. So great. I'm gonna blow through a bunch of slides today, talking about some policy updates. Those of you who have seen us talk about this before, some of these are going to be familiar, but of course, the day-to-day updates are going to be new ones. So there's still new information for you. I want to level set. I always like to level set here about the political reality. It is a mess. It remains a mess. It's been a mess for a while in Washington. Part of that is just sort of the nature of the system we have created, where congressional districts are not very competitive and gerrymandered to a degree where we've sort of further entrenched people who don't want to work with each other. And then that leads, there's no consensus building, there's no give and take in negotiations. The Democrats barely control the Senate and the White House. Republicans barely control the House. Some could even argue it's not in any control right now. And they have to work with each other to get anything passed. And so the result is, of course, nothing passes. It's been a wild year. Congress, you may have heard about the potential government shutdown earlier this year, multiple times. And we came to the line multiple times. They kept passing very short-term funding bills. They're supposed to pass a funding bill in September of each year, September, October of each year for the following year. They did not pass the current one until the end of March. So that was almost 6 months late. We're also going into an election year. And when you go into an election year, it's always it's an us versus them feeling in the world. And people don't want to work with each other to pass things. Why would you help your enemy if it's going to help them get reelected? And so we have the House, the Congress, the president. Everyone's up for regular election. We've got a lot of important champions of our issues are going to be going away. And this headline stuck out to me. This was a couple of weeks ago, and I thought it was very interesting that it is so dysfunctional that half of the senior staffers in Congress want to quit. And that's a problem, because anyone who's been on Capitol Hill knows that it is the senior staffers. It is the staffers that actually really do the work. Everyone else helps set the tone and helps set the agenda, but the staffers get things done. And so, when they're disenchanted with things and want to quit, it's not a good sign. So, I'm going to talk a lot of issues, but I just want to level set, because it's working in government relations can feel like a very, you push the boulder up the hill like Sisyphus. For those of us that studied Greek tragedies in high school, but you push the boulder up the hill, and eventually it slides right back down. But maybe you get there at some point. Maybe you achieve something, and that's what we do here. Is we constantly keep fighting for the issues that matter. Against this backdrop, of course, is healthcare and costs and affordability. And this is a poll. These poll results were just put out a couple weeks ago, looking at costs and affordability from the Kaiser Family Foundation, very well-respected organization. And you'll see, healthcare costs and affordability are sort of top of mind issues for voters and for the public. And that's no surprise. That's been an issue for us for a long time. I put costs in quotes, something I'll talk about in a second, but it's what you get on the invoice when you go to pay your insurance benefits, or when you go to pay your copay, or for at the prescription drug counter. And those are often not the real numbers. That's the muckety muck that all these middlemen and all these various stakeholders in the system, when they put their pressure and they take their cut, it raises costs, and it is a very challenging situation. So you go against that backdrop of politicians not getting anything done. You have the voters who, for years, consistently have pointed at healthcare costs and affordability as being a big issue. We're going into an election year, and drug costs, healthcare costs, those are going to be really some of the top issues. The passage of the Inflation Reduction Act, or the IRA, that allows for Medicare drug price negotiations, that is really sort of the crowning achievement that a lot of Democrats will be running on. See here, this was just a couple weeks ago, President Biden did, talking about lowering healthcare costs. It is the stump speech that a lot of politicians are going to be running on. When they talk about inflation, they're also going to talk about healthcare costs. When they talk about all these other issues, healthcare costs is going to constantly be what they're hearing about. But of course, with the passage of the IRA, our politicians in Washington have been able to turn their attention away from what has been their traditional punching bag, which is big pharma, because they feel like they got their pound of flesh. They feel like, oh, we've got Medicare drug price negotiations. We've dealt with pharma. Now we're going to focus on some of these other things, and I'll talk a lot about them, but namely PBMs, hospitals, and insurers. That doesn't mean pharma's off the hook. That doesn't mean that they're not going to pay attention to them and keep holding hearings. Bernie Sanders in particular loves to hold hearings on pharma and all the drug prices. But it has allowed them the breadth and the attention span to turn towards these other big issues in our system. And of course, these are all the issues that COA and CPAN cares greatly about. And so what we're going to do for the rest of this presentation is talk a little bit about our 2024 advocacy priorities, what we're really focused on, and then what's on our radar screen, right? So every year at the end of the year, we bring together representatives of our practice leadership. We have a government affairs and policy committee. We have a pharmacy network. We have a practice leader and administrator network. We bring together our government relations team. We all sit together in a room for a day and we say, like, what remains undone, what is top of mind for you right now, and what is keeping you awake, and what can we focus on in the next year, and then also what's realistic, right? I mean, go back to that first slide, right? We could say we want to put a man on the moon, but if that's not a realistic achievement, given the political scenario, that's not something we need to focus on. So we boil it all down. This is just really high level. The real document when we come out of this working group is 5 pages long with a bunch of sub bullets, but payments and reimbursement, that making sure your doctor gets paid adequately for the care that they provide, so they can frankly keep their lights on and keep their doors open. You'll see a slide later on that talks about inflation and the cost that running a practice has. PBM reform, that's sort of the biggest issue on COA's radar screen these days, and sort of all of the things that go around PBMs. Dealing with hospital competition, provider wellness, and workforce, so making sure that your doctor and your nurse and everyone in the practice still wants to be there tomorrow and doesn't go and retire at the first chance they get. We have created a system with so much bureaucracy and so much red tape for them actually taking care of patients that they often, are looking for an escape valve if they can. In that realm, prior authorization, utilization management, those are things that get between a patient and the treatment that they need. Finding solutions to drug shortages. We've had endless cancer drug shortages over the last decade, and we're nowhere close to solving that problem. And it's going to come back if we don't actually do something about it. System transformation. This is a little bit of a wonkier side of things that we focus on, but it's sort of helping our practices evolve into the next. What is the future? What is the next thing down the line for how they're going to be paid, how they're going to deliver care? How do we do that to make it better for patients? And then, of course, all of that is, we want to improve cancer health equity and reduce disparities in cancer care. These are the big. All of that then sort of translates into what we're tracking as the year goes on. These are sort of big layered issues that I'm going to talk in more detail about, but there's a lot of vehicles in Congress right now for addressing all of these issues that are keeping our practices awake at night. And I know I'm on the CPAN chat, so I want to make sure and say, like, a lot of times, these things do sound like, oh, they're the practice operations and they're for administrative and it's a business issue. That may be true, but at the end of the day, like, they also impact patient care. And it's so easy to fall into the trap of just saying that this is a business fight between a PBM and a practice, or between an insurer and a pharma company. But if a patient's drug goes up 50% or 300% or 3,000% in cost because of all this stuff in the middle of the system, because of where they're treated or because of how they get their drug, that makes a big difference in cancer care. And so that's what we focus on, and that's why we focus on this whole range of issues. It's, as our executive director Ted Okon always says, like, it's about the patients. We always come back to that, and all of these issues sort of ultimately impact patient care. So PBMs, that's the sort of the PBMs, and that's sort of the marquee issue that we are focused on right now. It's one of the sort of the core pillars of what we're going to DC for our Hill Day on May 8th. Actually, the overarching theme of our Hill Day is about middlemen and getting them out of patient care and letting the patients decide what they want. And of course, you know, the biggest culprit in recent years has been pharmacy benefit managers. And I put this slide up just for those of you that aren't super familiar with them, but you can go and learn a lot more about PBMs on our website, on the CPAN website. We've got numerous videos on our YouTube channel about it. So there's a lot out there. PBMs, though, you know, as I said, you know, they are impacting patient care tremendously, delaying and denying care, forcing patients to use mail order pharmacies, fail first step therapy, prior authorization. These are all things that you have that you've probably heard us talk a lot about in the past, but you know, they're still big issues for us. And on the practice side, you know, they impact the ability for the practice pharmacy to continue operating because of low reimbursement or other bureaucratic challenges that they throw that impact patient care. So PBMs is where we are really focused right now. It's where a lot of our energy is where we're going to be focused on when we go up to the Hill. We've also published a lot of patient horror stories detailing the impact on patients and what the patient experience is. So, you know, you can scan this QR code to learn more about that. You can also just go to our website. It's under resources and PBM horror stories. Where are we right now in Washington on PBMs? It's an unfortunate situation. I get accused of being a pessimist, but I like to consider myself to be a realist. Where we are with PBMs, you know, going into last year and this year, as I said, the Inflation Reduction Act allowed Congress and policymakers to turn their focus to other issues such as PBMs. We were very hopeful. There were hearings after hearings, 25 different bills at least being pushed, some really big and comprehensive ones. They were bipartisan. Everyone was behind it. And then it sort of fizzled out. And it fizzled out for a lot of reasons of what happens in Washington, one of which is that they let the perfect become the enemy of the good, where in negotiating with issues, they did not, you know, one side didn't want to cede ground to the other side. One side wanted to do more than the other side was willing to allow happen. Also, PBMs, you know, are multi-billion-dollar corporations. And they have a lot of lobbying power and a lot of influence, and they employ a lot of people. So it was we're in a tricky place right now with PBM reform. Essentially, the vehicle where PBM reform would have seen the finish line was going to be in those government funding packages that I referenced earlier that were finally passed in March. And when they came to the finish line, PBM reform was not included there. So we are now sort of in a position where we're trying to figure out where the reforms are going to proceed, if they proceed, and ideally not stop the momentum. And that's one of the messages we're going to be delivering when we go to Capitol Hill in a couple of weeks is, you know, don't stop this momentum. We need to address PBM reform. On the cycle, you know, we're entering the election season. Not much is probably going to happen between now and the elections. That's just a realistic thing. Everyone's on the campaign trail. They don't want to work with each other. They haven't worked with each other yet. Why would they suddenly start working with each other when they're asking to be reelected and tell you that the other guy is the wrong choice? But after the election, we enter what's called the lame duck period. That is, the November to January period when those people who either lost their election or have just been reelected, and there's sort of that buffer period where Congress has the ability to do things and not face some consequences from it before the next Congress is sworn in. And that's a good opportunity during lame ducks for things to happen. And that's what we're hoping, is that during the lame duck session that we get some of these PBM reforms advancing, because we were so close. I think even if it doesn't happen, of course, I don't have a crystal ball. I just, it's all guessing, and there's a dollar for everybody in Washington who can guess about what the outcome of politics and votes are going to be. We'd be a millionaire. But I guess PBM reform has come so far that we are going to see something at some point, whether it's this Congress or the next one. But we are so close, and with advocacy, we're going to get there. So look for some more movement on PBM reform towards the end of this year, and if not, in future Congresses. Now, what does that look like? Just sort of top 5 things that I think that sort of commonalities that we see on bills to reform PBMs. Transparency, sort of shedding light. Like, there is so much fine print and so much trickery that goes on with drug prices, with rebates, how they're defined. Remember, PBMs are supposed to negotiate rebates and better prices for everybody. So that transparency really helps you understand what that is. Where is the money going? What it's being recorded as? What's the formulary? And what's the design? What's the plan design is? So transparency is just hugely important. But understanding a problem and stopping a problem are 2 things. And so we can't just give up at transparency. We can't just say, oh yeah, now we all know these problems are happening, but we haven't actually passed any laws to fix them. Because if we just pass if Congress just passes transparency, then we're going to be in the same position, having the same advocacy chat with these other 4 bullet points as to what we're talking about in 3 years, because it takes forever to get to this point in the finish line. So other issues that need to happen, it's spread pricing and banning that. That's something where a pharmacy is reimbursed less than what the PBM purchased the drug for, and the PBM pockets that difference, the spread, as profit. That drug price arbitrage is something that PBMs are very good at doing, and they've been doing for a long time. Ensuring that patients get the benefit of the rebates, the discounts, et cetera. Believe it or not, PBM's role is to lower the cost of drugs, but then they go ahead and oftentimes are redefining what those rebates are, redefining what those dollars are. And that goes back to point number 1 on transparency, and not letting the patient benefit from that rebate. So rebate pass-through, ensuring those rebates and discounts go to benefit a patient and to benefit the plan sponsor, aka the person who's paying for the insurance plan or funding the insurance plan for their employees. Reducing patient out-of-pocket costs that comes from the rebates and everything, and ensuring that patients get a lower price. Remember earlier I said cost in quotes. Oftentimes it's like buying a car, right? The sticker price is $50,000, but they'll give you a discount at $35,000 or something like that. With drug costs, oftentimes the sticker price might be $100 for your medications. The PBM has negotiated that it'll be that it's $80, but then they charge the patient $100. Well, why, if that drug price is actually lower, why is the patient being charged the full freight for it and a markup for it? It does not make any sense if we truly want to address drug pricing. And then delinking drug pricing from PBM profits. That's oftentimes PBMs make their money on a percentage basis from the drugs that are distributed. And that incentivizes them then to encourage and keep on formularies higher cost drugs. And so, let's say that there's a generic or a biosimilar option. A PBM may sign a contract where they get reimbursed more for the higher cost drug. And so then they want to push that instead of letting a patient get access to a lower cost drug. And so all of these types of things come together to really impact patient costs and overall healthcare spending. And you go back to that slide about voter concerns that healthcare costs and medication costs are some of their top concerns. Well, this is a very straightforward, easy way to bring transparency and clarity into what those costs are and address those and stop these multi-billion-dollar corporations that don't directly provide any patient care from benefiting from the system. Some very famous economists have called this type of middleman a tapeworm, where they just sort of take and take and take from the system without actually providing any benefit. Related to this, something that we're also going to be focused on when we come to Washington in a few weeks is this reinterpretation that took place last year on drug delivery. The federal government has decided, in a quietly published frequently asked questions document, that practices could not deliver oral drugs to patients, that they have to be picked up in person. Anyone who has dealt with cancer or been a caregiver to someone with cancer knows that it is a long and arduous path during treatment, and you can't often make it to the practice to pick up your medication every month. And essentially, what CMS did was that no, friends, family members, caregivers cannot come and pick these drugs up. No, the practice cannot courier them or mail them to the patient. They have to show up themselves. They say that if a practice were to deliver that, it would be what's called a Stark Law violation, which is essentially a very 40 or 50-year-old law that's meant to stop healthcare providers from self-dealing, meaning self-referring patients. But these are patients already under their care. These are patients already receiving medication. If the patient happened to be standing in the waiting room, there's a pharmacy counter right there. They could get their medications from. But there is they've suddenly decided to reinterpret a lot of existing practice and restrict patients. Now they say that this isn't a problem for patients because they can now just go get their medication through PBMs. Now, as we just got done talking about, dealing with PBM issues causes all sorts of other problems for patients: delays, increased costs, waste, etc. So we are really focused on this, and that's going to be one of the things that we go and talk about when we're in Washington, and ensuring that Congress knows that these types of problems and intermediaries in our system really need to be dealt with. With that, I'm going to end on two little slides. A reminder: get involved. This was just a short taste of what we're talking about. But you have a voice. You have a voice federally. You have a voice at your state level. You have a voice through CPAN. Patient stories, survivor stories, caregiver stories, really important to what we do, and really important to our mission and our advocacy. And as Rose mentioned, one of the ways you can get involved is joining us in Washington on May 8th. So, you definitely, if you're interested in doing that, reach out and get in touch with us. Thank you, Rose.
Thank you, Nick. And just, for all of our listeners and attendees, obviously, this is a lot of these topics are very, very complex and comprehensive. But as Nick mentioned, we do have great information in very plain language on our website, whether it's PBM fact sheets. We have videos that are only 2 minutes long. In fact, that's something we talked about in our session, is it only takes 2 minutes to watch a video, and it helps you have a deeper understanding of PBMs. And just to reinforce what Nick said, everything that we do, even when it sounds very wonky, as Nick likes to say, it really comes down to, we don't want any interference between a physician and a patient. So that's what we do at CO and CPAN. Thank you so much, Nick. And next month, guess what? Our favorite topic, an expansion of what we're talking about today, is more of a deeper dive, we'll say, into pharmacy benefit managers. And many of you may know Dr. Deborah Pat, Vice President of Texas Oncology. She's extremely well known on the national landscape and is very, very highly regarded. So join us to learn even more. Thank you so much, Nick, and thank you to everyone. Enjoy the rest of your day.
Thanks, Rose.
Thank you. Bye.